Thank you for the opportunity to present this case to you. So my presentation is entitled The 4S of 1F, and don't worry, you will find what the F and S stand for. The first case is about a 58-year-old woman who had a typical angina on exertion despite OMT. She went to a hospital with PCI facility. They did coronary angio and find three-vessel disease and did a PCI of the circumflex artery with implantation of one drug-eluting stent. But the patient did not have any improvement of her symptoms, so she was referred to our clinic for further evaluation. The ECG and echo at rest were normal. We did a coronary angio, and this is the RCA. This is the left system, which shows a patent stent in the circumflex artery. You can see a stenosis of the LAD in the first diagonal, and at the end here you can see the RCA spider view. The RCA is to be seen at the end. So we stop here, and the syntax score was 17, so we offered the patient cabbage because she was young and she did have diabetes, but she refused. So we went further with the intervention. We took a Judkins Wright 3.5 6 French catheter, and we did a dissection of the radial artery here. This lesion was crossed with a terumo. This lesion was crossed with a terumo glide wire. Next, we put a wire in the RCA. This is a whisper guide wire. We did a few balloon dilations, and we saw that there is a stenosis of the PD. So we put the wire from the PL to the PD right here. A few more balloon dilations. And on the next hard dye injection, this is what we saw. The hematoma went straight to the crux of the heart. Oh, it's an F. So this is what the F stands for. F stands for the F type of coronary dissection, which is a iatrogenic one from the catheter. Here are the 6 types of coronary dissections according to the Heart, Lung, and Blood Institute. C through F are the bad one, with F being the worst of them, with the highest mortality rate. So this is the algorithm for catheter-induced coronary dissection. And we had a wire in true lumen, so we went straight for the stent implantation. Now here's a question for the listeners, which we'll discuss at the end of the case. Should we stent proximal to distal or the other way around? In our case, proximal stent was placed. This is 3 by 48. Then we did a balloon dilation of the middle RCA. This is the stent implantation. And this is after the balloon dilation of the middle RCA. Blood flow is restored. We then saw the PD, and PD needs some attention, which means 2.5 by 23 millimeters. We finished with a 3 by 38 stent in the middle RCA for the full metal jacket look, and this is the final result. So I began with the name of my presentation, which was the 4S in 1F. We all found out what F stand for, and what the 4S stand for was in first place stable, hurries of no help, smart. If you have dissection of the left main, you probably want to perform stenting in the vessel with the more hemodynamic significance. Swift be prepared and be ready for CPR, for pacing, and maybe intubation, and stent. Barrel stenting is probably your best choice to save the patient's life. And this is from me. And now maybe we can discuss the proximal to distal and distal to proximal approach.
Hello, Robert. Your comments?
Hello.
Did you follow the case?
Yes, of course. I'm sorry to be late a little bit because of familiar affairs. Anyway, this was a nice presentation. How can we deal with a dissection even with hemodynamic compromise? Proximal or distal, everything depends on anatomy. Since anatomy is relatively easy, there is no impairments to proceed with a second stent for distal location. Proximal can be obvious, but sometimes it's not so easy. So therefore, in the big therefore mainly I start from distal.
I misunderstand. We start?
He will start from distal.
From distal, okay.
I have two comments. First, this small high takeoff radial.
Yeah.
Something we were always doing in such a small vessel was to go down a bit and look at the connection at the elbow level. At least a third of cases. Sometimes this is very complex, complete loop, and so on. And sometimes it's very easy, so you can move to the bigger vessel. So this was the rule. You see a high takeoff, go down, inject, look at for connection. And after the dissection, I would have nearly the same position as Robert. Have you attempted to leave unstented the bifurcation? Was it intentionally, or the two stents, the PDA and the distal right, were really overlapping? These are the two stents between the distal right and the PDA were overlapping?
Yes.
Or you left some place for the from the PDA?
Everything was
So what I observed with this dissection was it probably stopped just before the bifurcation.
No, it was clear that was iatrogenic dissection, and we decided to fix the entry of the dissection.
Yeah, this is something we always say, but this dissection is not open.
Yes.
Distally. So when you arrive with the stent proximally, you are pushing some blood. And sometimes you increase the dissection. Personally, I would have put the first stent distally.
Distal to proximal. Okay.
And also, of course, it's easier, I discussed that many times in the meeting, if you do antegrade and you can manage, if we can say, the length of overlapping, not having mistake of 15 overlapping, or no. But here, I think it was certainly a better solution to stand distal.
Okay.
But if next year I can bring you an invasive, iatrogenic dissection of left main with complete occlusion, repaired without CK elevation.
We have also the same experience several times.
So don't worry, we all had this problem, and okay.
In fact, in my view, these are two different things. First of all, I think if you have a dissection, probably you have to cover the entry site. And here, probably I will do the same because this dissection can go retrogradely to the aortic root. If you have to do something and there is a big hematoma, probably what you have to do is to stand distally to prevent this hematoma to go and additionally dissect the distal part of the vessel. I have seen this with George Dangas in Colombia, and this is really a very bad option. So you secure if there is a hematoma, secure the proximal part, the distal part, And if it's necessary to stent, you're sure that the hematoma is going to dissolve into the vessel wall, not distally and disturb the vessel's periphery. This is something that I would make a comment, but this is really when you have a great hematoma. And usually it's
May I have a provocative question? What about intravascular imaging? Does it help? And how much it can help?
You know, this problem was created by too much proximity between a guiding catheter and a small vessel. Personally, I would avoid to put anything else in the vessel. I'm not sure that we can choose the position of the stent in this situation using an IVUS, because you have no flow. So, yeah, you know where your IVUS is, but you don't know in which part of the artery the IVUS is. I mean, really, you know, at the millimeter. So I don't think we'll bring anything interesting. So I won't do. And of course, this is the right coronary artery, but you know, if you occlude during a coronarography a left main, you don't have time to do IVUS.
But, you know, I'm partially agree with you, because first of all, with IVUS, you are able to distinguish whether you are in the true lumen. This is one important, let's say, argument. And the second one, after first stabilization of the flow, to choose the right sizes of stents, and let's say to assess how long should be stented area was. IVUS, it's not so bad. I would let's say consider the usage.
Yeah, I can hear that, but you know, the wire was not lost, so he was for sure in true lumen. And yes, after positioning a stent proximally, you can look. Maybe sometimes, you know, I remember this is another context, but this is a spontaneous coronary dissection that we see. For example, I have a hard remember of postpartum spontaneous dissection, and you know, the rule is to try to maintain medically with hypertensive drugs, and to go forcefully to treat this kind of lesion. But in this situation, we try to close the entry point and do nothing else. This is what we do normally in such an anatomy. Because when we begin, then you put a stent proximally, you can put a stent distally, and another stent distally, and with a catastrophe. So that is really maybe another context. But yeah, the idea to do less is probably a good idea too.
Okay, so
the next case is going to be presented by Dr. Chilingirov. Worst.
Just a very short comment about the problem generated by the guiding and the dissection. The dissection was created by an injection without pressure.
Hydraulic.
And in our group, what we say is you have a doctor taking care of coronary arteries, and not a second doctor looking at the pressure. He won't do. He's only looking at the pictures. So we have a nurse to look at the pressure, and she is pushing the button of the machine to inject. And if you say, okay, test, and she said no, this is no. So you can have a third doctor, but he's just behind the fellow, for example, working at the table. I think a doctor and a nurse is better than two doctors, but my opinion.
I prefer this couple.
Thank you. I will present the case on behalf of our clinic. It's about a 63-year-old gentleman who in fact is a friend of mine. He has typical risk profile with hypertension and dyslipidemia, who came to us with high-grade stable angina under optimal medical treatment. He suffered anterior STEMI 2 months ago, and balloon angioplasty was performed in another clinic. He has preserved kidney function, ECG showed no STT changes, the echo was also normal with preserved ejection fraction of 55, with no low motion disorders, and with mild aortic regurgitation may be due to dilated aorta. In this index procedure, he was referred for CABG. But in fact, he refuses CABG, and that's why he came to me, asking for what we can do. This is the right, this is the diagnostic angio. As you can appreciate, there is proximal severe stenosis. The left system seems a bit more complex, with calcification and with severe osteo left circumflex lesion, a small first marginal branch with osteo and proximal lesion, and one big early diagonal branch which is diffusely diseased osteally and proximally. The LAD also is calcified with 2 severe lesions in the proximal and mid segments. We can summarize the anatomy on the left as the following. As you saw, there is a tight osteo lesion of the left circumflex, small marginal branch with osteo lesion, one early big diagonal branch with severe osteo and proximal lesion, lesions of the LAD in proximal and mid segments, and diffusely diseased second and third diagonal branches. We staged the procedure, and we started with the intervention of the right. We chose 4-0 stent, which was implanted osteally, post-dilated at high pressure with 4-0 non-compliant balloon, with this final angiographic result. At that point, we have to take our time to think what we can do on the left. We proceed with dobutamine stress test, which induced and low-dose dobutamine ischemia in 4 segments of the left circumflex territory. So we have to take care of this osteo lesion. And our plan was to do all these lesions at one session. So we decided to start first with the LAD in the mid segment. After that, to prepare and to resolve the lesion of the diagonal branch. After that, to treat the ostium of the diagonal branch, the left circumflex osteally, and to cover the whole severely diseased LAD and the left main with stent. This is the baseline angio. As you can appreciate, we have femoral access, 7 French, EBU 3.5. We started with the LAD, pre-dilation with 2.75 balloon NC with high pressure. We implanted a stent, 2.75 by 28. After that, we moved to the diagonal branch. We pre-dilated with non-compliant balloon again at high pressure, 2.5, and implanted a stent in the diagonal proximally. Important step is that we pre-dilate also the ostium of the diagonal, again at high pressure. We moved to the LAD. We wanted to touch the lesion to see how it expands with balloons. So we pre-dilate with 3.0 balloon by 15, non-compliant balloon. You can appreciate that it's fully opened. And we choose stents for the diagonal and for the LAD, 2.5 for the diagonal and 3.5 for the LAD. They were placed as for a crush, and we implanted the stent in the diagonal branch, just osteo, but to cover the whole ostium of the left circumflex of the diagonal branch, protruding enough to be crushed and to cover the ostium. So we have this stage till now, and we move to the left circumflex. Before that, we wanted to make sure that the stent in the diagonal branch is fully expanded. That's why we use 2.75 non-compliant balloon, again on high pressure, to ensure that. And we move to the left circumflex, which we pre-dilate with 3.0 non-compliant balloon. We placed a second stent in the left circumflex, keeping the stent in the LAD undeployed, and implanted just like in the previous bifurcation, austerely, but protruding in the left main in the LAD to cover the whole length of the ostium of the left circumflex. We did post-dilatation again on high pressure of the ostium of the left circumflex before implanting the stent from LAD to the left main, covering also the ostium of the left main. This is the result just after the implantation of the left main stent. And we started the work with the bifurcation and post-dilatation. We started with the LAD bifurcation. We recrossed, we post-dilated with 2.75 balloon the diagonal on high pressure, with 3.0 the LAD again on high pressure, and we did the kissing. After that, pot for the LAD, 3.5 balloon. And we did a pot for the left main. It's an important point which ensured the easy crossing, recrossing of the left circumflex. And you can see for the fluoro how easy the wire went into the left circumflex. Again, pre-dilatation of the left circumflex of the LAD, after that kissing, and final pot for the left main. All the procedure steps are completed, and we did something like double but non-decay crush. This is our final result. We were happy with it, but we checked that also with IVOS. As you can appreciate, this is the bifurcation of the left main, the LAD and the left circumflex. Minimal stented area of the proxium and the ostium part of the LAD was 7.5 square millimeter, and for the left main, minimal stented area was 12 square millimeter. Thank you.
So the discussion is open.
So I have only one comment. This is old-fashioned crash techniques used in these complex case. And I wonder whether it was safe for such a, let's say, long stenting distances to use this approach. I am afraid of the outcome of the patient.
So in fact, we did a couple of cases in that fashion in the past. The most important point and the aspect of this procedure is to open the ostium of the side branch and to ensure the complete opposition of the stent struts, so that when you crush that stent with the stent from the main branch, you can easily cross with wire. And after that, doing high pressure dilatation of the both branches simultaneously and one by one, you ensure that the carina is on the right level, the stent is optimal deployed, and the struts are well opposed.
That's very good. Your experience is very important. Of course, you felt comfortable during this procedure for sure. The positive moment of this strategy was IVOS inspection to optimize the results. But I'm afraid that in the case with much more calcium presence, this result was not so, couldn't be so good. So might be, I would agree for this approach with a pre-procedural IVOS assessment, because since there is a lot of calcium where the additional devices should be used, I would go for that. Otherwise, I prefer to create much better metal carinas that is performed using these old-fashioned crash techniques.
Yes, thank
But
you for
congratulations. So at the end, that was very nice.
as a
IVOS assessment showed good result.
Is a comment. let's say, frankly, I'm not a big fan of decay crush. And what we have as experience, especially in our center, most of the double stenting bifurcation with double stents are crushed. Because the reasons are very different, and I think because usually you use crush in front when you have a great possibility to lose the branch and it is very diseased. And usually when you use it, there is a discrepancy, big discrepancy between the diameters of the main branch and the side branch. This is what we have as an impression. And we have more than 400 already left mains, which we have followed for more than 8 years. A mean follow-up is at least 4 years. The median of follow-up is at least 4 years for, let's say, at least 200 of them. And we have strict follow-up. We have an annual follow-up for them in on the second 6 months, 1 year, and if necessary after that. And I would say the results of these crush techniques are quite good. It depends how you do it, and the reason for this is, in my view, is because modern stents are very thin strut, and they can allow you to make a very good position and crush the stent very well. We're using minimally protrusion into the into the main branch, and this is helping us to finish the procedure with final kissing balloon, which is very important in all double stent techniques, which was not the case in the previous studies in which we know the crush technique, it was not possible to make the final kissing balloon inflation. Any comments? And finally, there was a study in which publication with meta-analysis which did not show disadvantages of the double kissing crush compared to the convention.
There is several studies. The one of China, of course, is in favor of decay crush versus normal crush. So normal, old-fashioned crush. This was decay crush 1.
Yes, that was...
in fact, decay crush is always better than others. So that's better than culotte, better than provisional, is better. So I share the opinion of Valerie on all this analysis. First, I have to say that when you are following your patient, you are doing an action of clinical research. That's very important. Of course, you can have a lot of patients, and don't know what are the results of what you are doing. This is very important to do that. It's important to know your results, and maybe it can be important to report and even to publish if they are original. So that's the first point. The second point, I have to say that I would have treated all these lesions, but completely opposite order. Of course, stenting the main vessel, proximal to distal, and limiting my overlapping to unintentional tap, as we seen yesterday night. So, of course, there are several ways to do that. So your result is excellent. So now we wait. You have to wait for the angiographic result, which is scheduled. In France, we are not allowed, so we don't do.
Okay, so thank you so much, and we will move to your next case.
Dr. Nenov is going to present it.
I'll present a recent case from our clinic. It's about 61 years old male patient with typical risk factors for cardiovascular disease. He's with stable angina class 3. Known left main and 3 vessel disease, 2009 at the age of 49. He was with myocardial infarction, and it was performed primary PCI of circumflex artery with 1 bare metal stent. 10 days later, because of severe symptomatic, it was performed CABG with arterial graft to LAD and 2 grafts, venous grafts to right coronary artery and the first marginal branch. The patient is with atrial fibrillation, with Wegener's disease on corticosteroid treatment. Optimal blood pressure, heart rate. From ECG we have sinus rhythm with Q waves in inferior leads and negative T waves, first AVL, V3, V6. He is with preserved left ventricular function with basal and mid-inferior and inferolateral wall akinesia and anterolateral hypokinesia. The patient is also with slightly impaired renal function. You can see optimal medical therapy. Here you can see the angio, this is the right coronary artery, with the severe tortuosity and tight stenosis in proximal and mid segments. Occlusion of the left main and occlusion of the two grafts, vein grafts. One excellent working mammaria. You can see from the retrograde flow that there is significant stenosis of LAD in mid-segment after the diagonal branch, and osteostenosis of the LAD and circumflex artery, patent stent in the proximal segment of circumflex artery. Schematic, this is the situation in this patient. We performed stress echo and we see inducible ischemia, large lateral wall ischemia, with a basal and mid-inferior wall cicatrix. After discussion in our heart team and discussion, of course, with the patient, we decided PCF this occlusion of left main. These are and the recommendations of the European Society from 2018 and also 2021 recommendations from the American Society. The plan was to recognize this left main. Right femoral access first and left radial access for the Lima. Guiding catheter ABU 3.56 French. Microcatheter fine cross, and the first wire, it's Gaia 1, Gaia first. You can see that the Gaia first got in this small intermediate branch. We try to change the position, change the direction. Maybe some course is subintimal in the left main. Other projection, other try. We change the wire with, in the position with the Gaia second. We have some success forward to the LAD, and we try in this direction. Gaia 3, the next wire, and you can see that it's subintimal in the proximal part of LAD. We try to change the direction and to get into the vessel. And after a moment, you can see the wire is surely subintimal, and there is subintimal space with impaired ostium of the LAD. We try to change that, to fix that. But we have compromise in the ostium of circumflex artery. You can appreciate it from here. Then we have, of course, slow flow in the circumflex artery, and the patient was getting worse with severe complaints, severe chest pain, dyspnea, lowering the blood pressure, desaturation, severe ECG changes. We start catecholamines, diuretics, nitro, opioids, oxygen, and think about what to do. Maybe bailout retrograde strategy to restore the flow to the circumflex artery. But there is an issue. This is the tortuosity of the mammaria, and some concern to have low flow in the mammaria when we cross with a balloon or microcatheter. This is the problem. This would be a disaster for the patient. Still on medical therapy, aggressive medical therapy, there was better flow in circumflex artery, stabilizing the patient's hemodynamics, reducing complaints, no ECG changes, and we decided to stop the procedure. The patient recovered fully, no complaints. Yes, the day after, there was a sign of myocardial injury with high troponin levels, but no ECG changes, significant ECG changes, no problems with the echo, no complaints. And now, still the patient is with high-grade stable angina despite the optimal medical therapy. And now, what do you recommend? What will be the next? Radio PCI and how, if, or radio cabbage?
A nightmare.
Yeah.
So if you want to go to surgery, you have to find really a very good surgeon.
Yeah.
Because I remember cases like this, the result was they cut the mammary, they put a saphenous instead. Of course, they revascularize the patient, but...
The occluded graft was to the circumflex, or? Yes. Probably you can try
You have attempted to
pass
go
to
in the mammary?
only
We
as a
tried,
retrograde
but
option.
It's more than
What
10
will
years,
occur?
so-
What occurs normally is that we are twisting you are straightening the mammary graft, and then you are also suppressing the flow. So,
Yes.
so I have observed that this is really.
We haven't recorded this, but the wire was already into the proximal part of AOD. It was easily go because the angle between the memory and the AOD is not that sharp. Because if it's too sharp, it's very difficult to manipulate and go.
Yeah, but the problem will occur when you will push material, you know.
When you put a microcatheter or balloon, probably it is going to straighten and.
Maybe redo PCI. What with you have to find other ideas. So.
Confiance.
It should be done. It is very. We discussed this with George yesterday too, and he was eager to do the case. But I calmed him down. But he says that it is really the main issue is that the only access is through the AOD. And if you succeed to go retrogradely, you can do this because with, for example, with Corsair, you can navigate these tortuous parts of the mammary without
you can try, and if you see there is no more flow, you remove.
But the problem is if you go retrogradely again, you should do the subintimal space coming from the AOD and from the left main, and that means you don't have a guarantee that you are going to...
Yeah, but if you do that, you can close the circle.
Exactly, you are going to preserve the circle.
Shortcut.
And there are no retrograde options. We seek for them from the right coronary
yeah, but
to
you have not re-injected the coronary. That was just to say you that. Maybe the situation of the circumflex was not as good as before, for sure. So now if you do a coronary angiography, maybe you will find collateral filling from the right.
You propose a slow...
Just do a coronary angiography. At what time it was done?
It was done before 2 months, let's say.
Yeah, if it's still severe angiography, redo a severe chest pain, redo an angio. Just redo an angio and reanalyze the situation. I will do that.
I mean, you propose slow closure of the circle in order to make retrograde collaterals from the right.
Yeah.
Robert, comments?
To be honest, it looked not so difficult. I predicted another kind of complications.
Thank you. We're sorry that we did not meet your expectations.
Because for patient luck, everything went fine, but still you have the problem, and of course patient has the problem. to be honest, I truly believe that highly experienced CTO operator could manage it probably with a bigger variety of wires. So that was not so aggressive. That was only Gaia 1, if I remember well. So might be there was a moment to use two lumen microcatheters to trying to reopen the, let's say, the circumflex artery. I'm not the best in this field, I have to say, because sometimes it takes so many hours to succeed. But I saw these kind of cases performed by the best CTO operators. Therefore, I would let's say repeat the NGO for fresh
That's a
assessment.
good suggestion, yeah.
And taking into account, let's say, one more attempt, but as I told you, with the best in the group. I mean, the CTO operator, taking into account much more sophisticated tricks, devices.
Following your idea, Robert, if they do a coronary angiography, they can also show the new imaging to a surgeon. Look at the best surgeon in Bulgaria, because he has to choose an alternative approach. Because if he goes through the sternum, we'll cut the...
No, but we have our...
So you may have some lateral... I know a surgeon in my place who is doing that for re-intervention, which is lateral intervention. Not the left, because the left mammary is used, so maybe right lateral intervention. Will be not easy, but...
No, but in our center we have a very good cardiac surgery, and the chief of the surgery...
Look at the case already.
No, but it's not a big issue. They are doing a lot of redo operations with working memory, even, and this is a usual practice. And they even asked for to do them a favor. We occlude the memory in order to achieve a good plagia of the small balloon over there to a low pressure, and they went with the patients into that. So it's not a big issue for them, this reoperation in a case of working memory. So this is something that we already discussed with the patient.
I think for me the good idea is to do an angio, redo an angio, and do a real discussion. I mean, art team.
I can share you also, at least to the moment, relatively low experience of our cardiac surgeons trying to do such a cases also with Da Vinci device. They have a new version of program, and they are very experienced with the usage of this device, 2-3 operators per week. So maybe this is also not so aggressive. It is really a minimal invasive approach. Okay. They are able to, let's say, to use right internal mammary artery as well.
How old is the patient?
60 years.
63.
Yeah.
He was operated 10 years ago?
Yeah.
2009.
So at 50 years old, you do angioplasty. At 60, 65, 70, you do surgery.
Yeah.
He has 2 saphenous vein grafts, 10 years. The risk of having the 2 saphenous vein grafts occluded at 10 years is very high. 50% occlusion, 50% stenosis. So 3/4 of them are not working. So at 60, even today, people are living more. Even at 60, I would privilege, even in complex lesion, PCI, and do surgery for 70 years old people like me.
This is what we have as a philosophy, really, just to postpone, if possible, the operation.
Yeah, this is, of course.
Just okay, so after so great discussions, we leave Valery to take the final decision about the patient. and responsibility against the patient.
Again.
And so let's go further with the next case.
Thank you. I'll start directly with the case. It's a medical history of our patient. It's not so old male patient with really unstable angina. The complaint started 2-3 weeks before the admission. He had normal ECG, normal echo, and the only problem of the patient that he was a physician. He was protected a lot, and he was admitted late afternoon, and we were pressed to proceed with the procedure and to do it on the same day and to be discharged next day. And we tried to deal his problem. Of course, we accepted, and we performed an angiogram. This diagnostic part of our procedure, you can see probably it's not well seen, but you can see the left circumflex has a tight lesion, and the artery is quite calcified. We don't have stenosis, tight stenosis, and LAD. This is the right. We have a moderate lesion, the proximal and mid part. And we decided to proceed for circumflex PCI. We decided that it's quite easy. The really low syntax score we cannot discuss with the surgeon for the surgical option. That's why we proceed. Our usual approach is a 6 French radial approach with extra backup guiding, 3-5 workhorse wire. We relatively easily pass through the lesion and try it with a semi-compliant 215 balloon, but it was not possible, and I decided to take a 6 French guiding extension catheter, and I passed the half of the lesion. It was not easy, but I dilate several times, but you can see the waist of the balloon. After that, we were 2 operators. The other operator take over, and we lost the access. And I said, okay, if we want to proceed, we should go with 7 French probably to increase the support with Amplatz and to prepare everything for rotablation, microcatheter, and so on and so on. The patient accepted, and we prepared everything, but the nurse said, oh, something's wrong with the old guiding, something missing, the proximal plastic part of the guiding is not there. I said, okay, I'll check in the brain. That's the main issue. I did just fluoro, and I couldn't see anything. I said, okay, somewhere in the legs, I don't care. I'll proceed with the angioplasty. I put a microcatheter there. I put back my wire because I couldn't cross the lesion. It was quite tortuous, calcified vessel, and I took the rota wire. I passed through the lesion, and I prepared everything for the rotablation. That's the burr. It's 1.5 burr, and I proceed with first run, second run, third run, and during the third rotablation, something get wrong, and the speed reduced, decreased. I said to the nurse, please increase the rate, the speed of the rotablator. She increased, but nothing happened. And finally, I was able to pull back the burr. And this time we saw that we don't have a gas in the bottle. Something wrong, technical issue. It was technical issue, and we stopped the rotablation. I took the same guiding extension catheter, 6 French. I passed distally. I started with the balloon inflations 1, 2, 3, 5, 10 times. And finally, went to ventricular fibrillation. How the team were there and spectate our procedure, and we immediately perform a cardioversion 2 times. The patient restored the sinus rhythm, and the hemodynamic was acceptable. And I checked the flow. Everything's fine, circumflex. I didn't have any explanation why, but I saw the flow in LAD. And this is the other projection. We have high thrombus burden. And I saw something in, I'm sorry, I'll show you again the, yeah, I saw something in the mid-LAD. I think it's well seen here. And yeah, the catheter. I changed the projection. There was a thrombus. I said I'll pass through, and I'll try to pull it back. And I was pretty sure that I'm in. If you look this image, I believe that I'm there. And I took a 2.0 balloon, passed through easily. I was really happy. I inflate the balloon. Yeah, we are almost there. I inflate, pull it back. I said, okay, I'll deal with this complication really easy. I'm happy. But the plastic part was out. I said, okay, this is a bit tricky to continue to try to crossing into this plastic part. And I fixed the tip of the catheter with a stent 3022. And we had acceptable result, I think. But at this time I saw that the flow in circumflex it's compromised, let's say. Its TIM is 0. I continue with some dilatation, some efforts to restore the flow. And this is the final result. I said, let's stop because I don't have any other option to continue. My gas bottle is empty. We cannot proceed. My support is good. I don't have any other options. We stopped. The patient was pain-free, normal ECG, and we were happy. We scheduled the patient for elective PCI and with throat ablation. We changed our bottle, and but the patient was, let's say, quite upset, and he found another hospital, and they deal the case with good result, 2 stents implantation. And when I watched the angiogram about 50 times, and I saw that this plastic part was there from the beginning in the circumflex artery. This is my view with the angulated microcatheter, and you can see that the plastic part is in the circumflex. And when I analyzed the case, probably I pull it back with the rota burr, and the plastic part went to the LAD. Few take-home messages, maybe more for me, not for you. But in cases of device loss, it doesn't matter. It's a tip of catheter or something where the strategy is somewhere in the legs. I don't care. Doesn't work so well in 100% of the cases. And double check is for the equipment, materials, and the preparation before to start the complex procedure is crucial to prevent a complication. And the only exception in our case for a classical nightmare case was that the procedure was done in Thursday afternoon, not Friday afternoon, as usual. Okay, thank you.
That's why I prefer left main, you know, instead of going distal in a small calcified vessel. So, yeah.
I just
I remember some nightmare like this. We all had.
Because Nikki showed me this case, and I asked him to present it there today. Actually, after rotablation, after unsuccessful rotablation, and I just told him that in that case I would go subintimally just to pass this calcification, because actually it was calcium ring which was impossible to dilate. And we have several cases with this strategy quite successful, when you cannot, for example, because we have now problems with supply with Rota, there is a problem for Bulgaria with the Boston Scientific, and we had to manage this situation somehow. And during the last month, I personally had 2 similar cases like this, and I had to go with like a CTO with Confianza behind the calcium to dissect, re-enter, and stand subintimally.
Dobrin, may I have a question about the intravascular lithotripsy? Is it available in Bulgaria? Or
Yes, not? Yes, but it is not
because
reimbursed.
I would follow this IVL technology after this, after rotablation, because I believe that this let's say, napkin ring, which was probably in this case, would suffer from shockwave technology. So my approach would be RotaShave.
I fully agree.
Shockwave.
I fully agree with you, but I couldn't pass through the distal lesion, and the shockwave balloon I have tried just few times. It's a quite bulky device, and I tried with 2O balloon and good new 2O balloon, and the balloon didn't pass, and I don't believe.
1.5. That was 1.5 bar.
1.5, but we stop in the middle of the plaque because this technical issue. We had a problem with the gas bottle. Okay.
Okay, so thank you, and now I will show you
The last case.
something not so terrible, very normal case. The first one is one solution for difficult side branch access, which was demonstrated from our Japanese colleagues maybe 6 or 7 years ago, but it is not so frequently used in the daily practice. So this is a 77-year-old male with stable angina from several years. Patient had hypertension and dyslipidemia, and he is ex-smoker with mid-range ejection fraction. So the patient had angio several months before this procedure, and this high-grade stenosis on the LAD was found. There was also on the proximal posterior PD branch some stenosis around 70%. So we proceed with the PCI to the LAD. However, despite a lot of attempts with different wires, it was not possible to cross the lesion into the LAD. This is Medina 110. So even after balloon dilatations of this critical proximal LAD, it was not possible to go into the LAD. after that, I placed proximal before the bifurcation stent trio, just to make easier manipulation with the wire. However, it was not possible again to do wiring of this LED. Then I switched to the reverse wiring with Sasuke and Fielder FC. So this is after special preparation with the Fielder and Sasuke. This is how retroversely we wired the LED. After that, the Fielder was placed deeply into the septal branches, and then the wire was Sasuke was removed, and it was exchanged for fine cross. Then we exchanged Fielder for Sion wire, and the procedure was straightforward afterwards. We placed additional long stent 2.5 to cover the distal lesion 2. This is distal optimization with the several kissing inflations for the distal part. Then we used a drug-eluting balloon for this diagonal branch, and then we made proximal optimization with kissing inflation, so-called POCI technique from us. We have now around 40 cases with this technique, and this is we use balloon for proximal optimization with the balloon for the side branch, and with this type of positioning. And this is the final result for this case. It is not something special, just because of the retroverse wiring, which I think that it is important to know. And despite that, it uses a double lumen catheter and hydrophilic wire. Sometimes it is useful just to know and to use it. And the second one, the second case is again a 63-year-old male with hypertension and dyslipidemia, with impaired glucose tolerance, normal lap exams, normal left ventricular ejection fraction, and the patient had a 3-vessel disease with critical osteo right coronary artery disease, and highly calcified left main disease, distal left main, with a huge aneurysm at the distal bifurcation of the left main. So we fixed first the right coronary, and then afterwards we wired both branches, which were demonstrated very well the morphology of this bifurcation, because this is 110 bifurcation lesion with a lot of calcium. And we made IVUS. IVUS demonstrated that almost on the whole length of the artery, the proximal LAD and left main, there was a huge arcs of calcium, and also there was this aneurysm, which was actually at the tip of the carina between circumflex and left main. As you appreciate, there was a really very tight stenosis at the proximal LAD, so we performed several predilations, and a long 3.5 to 3.0 to 48 millimeter stent was implanted. And that was the result after stenting. Then we made a pot with 4.5 to 6 millimeter. This is a specially dedicated pot balloon from Brosmet. This is now presented for specially dedicated for the pot technique. And again, we repeated POCI with the same balloon and the side branch drag-eluting balloon 3.0. And this is how is usually positioning, the usual positioning of the balloons for POCI, which ensures the optimal result. And this is how this bifurcation was finalized. Yes, it's not.
What was the size of the left main? Because we saw a huge aneurysm.
Yes, but aneurysm was actually at the tip. It was on the, like in the neuro aneurysm at the tip of the carina. So after stenting, it was just almost closed.
Yeah,
You can
I saw.
so that the size of aneurysm at the end of the procedure was almost disappeared. So actually, the stent pushed the carina and closed the aneurysm.
I have a question with this POCI technique. Do you afraid from some, let's say, compromising of the ostium of the stent to LAD in this situation, in the second case?
Afraid of?
Some compromising of the ostium, because
No.
maybe after this POCI,
No.
how it looks like with the IVUS,
No.
the ostium of LAD,
No.
because there are some, okay, you're sure with the ostium of circumflex, but I'm not
No,
pretty
I'm
sure.
absolutely sure about the ostium, and this is we are preparing a paper now about this technique. We made several bench testings about that, and the problem with positioning with the pot with POCI technique is escaped totally, just because you orient yourself by the markers of the balloons, and you place first your marker of the side branch balloon, the edge of the proximal marker of the side branch balloon is placed exactly at the edge of the stent. You see very easily the edge of the stent. You place inside the proximal marker of the side branch balloon, then you take your pot balloon, and the marker of the pot balloon is just, this is the one of the marker, the marker of the pot balloon is just neighbor to the side branch balloon. So the ostium of the main branch is completely covered and protected from the pot balloon. In this way, actually, you escape all the distortions which appear with kissing, with pot, side branch pot, all the techniques. This is the first technique which ensures complete coverage with two balloons. By this way, escaping all the deformations which can occur during kissing or pot or anyway.
And
We have, at the moment, we have 32 patients done in this way with excellent results. All the results are like that, much, much better than what you can achieve with any kissing or pot techniques. And you can trust me, I made a lot of pots.
And the balloon proximally is according to the proximal main vessel.
Yes.
Okay.
This is
We see.
pot. The balloon size in main vessel is the sizing is according to the proximal, like in pot, the same.
Okay. We will see.
Okay.
Thank you.